thrown it together in the last couple of hours. So if I've made any glaring errors, please someone point them out to me. In fact, no, don't point them out to me. You can just tell me at the end. So why are we talking about flexible training in cardiology and cardiac surgery? The workforce is changing, and this is from RCP data looking at the increasing numbers of consultants and higher specialty trainees who are working less than full-time, and who have chosen to work less than full-time since 2004. And you can see that the numbers are increasing, but it's not just women who are choosing to work less than full-time. There's men as well who have, there's more men over the last 15 years or so who have elected to work less than full-time. Why is it an issue? Why do we need to talk about it in cardiology and cardiac surgery? Well, in this changing workforce, we want to make sure that cardiac surgery and cardiology are attractive specialties and viable options for everyone who wants to do it. We don't want the fact that if you can't have a good work-life balance and you can't train flexibly, we don't want that to put people off, because we want to attract and retain the best candidates. And also, I think it's really important to make the point that flexible training or working can also improve well-being. And I think over the last few months or throughout 2020, we've all had unprecedented demands made upon us, and well-being is really important, and we need to think about that as well. And then when you look at what medical students want and what sort of things they consider when making their choices as to which area of medicine or surgery to go into, you can see that, and this is a big survey looking at a systematic review of medical students and looking at the things that they think about. And actually their lifestyle or flexible work schedule is important to the majority of medical students when making their decisions about which specialty to go into. So I tried to find a little bit of data looking at surgical trainees and cardiology trainees who train less than full-time. And I came across, like I say, I only had a few hours to put this talk together, and I could only find 2 surveys. One which I knew about because I did it myself with Hannah, and a surgical survey here which was done by the Association of Surgeons in Training and the Orthopaedic Trainees Association. And when Hannah and I were doing the cardiology survey last year or the year before, we found a real lack of data. There's no central collection or register of less than full-time trainees. We approached training program type directors around the country and found that in some regions, nobody really knew who was less than full-time. We didn't know what subspecialties they were in. So the data that I'm going to show you now is small data taken from these 2 surveys. So if we start looking at cardiology trainees, about 4% of cardiology trainees work less than full-time, and that's in comparison to around 15% of physician trainees as a whole. About a third of less than full-time cardiology trainees are male, and the main reason for a trainee to want to work or to work less than full-time is for childcare reasons. And when you then look at which subspecialty within cardiology less than full-time trainees elect to follow, you can see that the majority of less than full-time trainees pick heart failure plus minus ICC or imaging, with the rest picking the other specialties. But if you look particularly at devices, electrophysiology, coronary intervention and ACHD there, you can see there's the minority there. In electrophysiology, we don't think we have any less than full-time trainees in the UK. Now, like I say, there may be more recent data. This is all I could find that was from 2007. So for cardiac surgical trainees, there were 4 less than full-time trainees in 2007, which makes up approximately 2% of the total cardiothoracic trainee workforce. And when you look at all surgical specialty less than full-time trainees, about 7% are male. Again, it's about 80% elect to work less than full-time for childcare reasons. And then another statistic that I managed to find this afternoon was that just over half of less than full-time surgical trainees have experienced bullying or undermining behaviour. Now, when you look at, moving back to cardiology now, when you look at what trainees as a whole think about less than full-time training, this was some work that Hannah Sinclair did with some colleagues, and I'm sorry, I just realised now this doesn't actually project very well, but the expectation of support for less than full-time trainees, people weren't that sure whether they'd be well supported by the region as a whole, their supervisors or colleagues. But actually, when you asked the less than full-time trainees what their experience of support was, the majority of them felt very well supported. So I think sometimes it's about breaking down those misconceptions and trying to encourage people that actually, if this is something that they want to do, they will be supported to do it. So finally, just looking at well-being, this is looking at an RCP survey from 2018 of medical consultants. And I'm sorry, I couldn't find any data from surgical consultants, but I suspect that the numbers will be similar. So around half of substantive medical consultants reported they were regularly working excessive hours, with half saying that work had affected relationship with their partner, almost half saying that it affected relationship with their children, and almost a quarter recognising that they had features of burnout. And this was also identified by Health Education England in 2017, who said we need to create a culture change in the NHS and champion flexible working more broadly, both for trainees and beyond. So I hope that sets the scene a little bit for this evening. And what we're going to do now is move on to look at three different issues, that can be challenging for less than full-time trainees. So we've got 3 trainees, 2 cardiology trainees and 1 surgical trainee, who are going to take each of these issues in turn and give us their thoughts on that. So I will stop sharing my screen now. And I'm going to hand over to Hannah Sinclair, who is a clinical fellow in ICC and cardiac MRI at Guy's and St Thomas's. She's also the previous BJCA Women in Cardiology and Less Than Full-Time Rep. And she's going to talk about the ARCP process and how this should and could be adapted for the less than full-time trainee. Over to you, Hannah. And you've managed to share your screen, hooray!
The question is, will it move on to the next slide? So I hope you've got my slides as the backup. So thank you for the introduction and thank you for asking me to talk. I've been asked to talk about the ARCP process for the less than full-time trainee. Has that moved on? Excellent. So my objectives really are just to talk about the annual review of competence progression. I wanted to touch on the gold guide, which most of you will be aware of. I wanted to touch on current practice and talk about my experiences. So as most of you will know, the explicit purpose of the ARCP is to document progression of a trainee against the curriculum. So it's a formal review, and the ARCP decision aid is used as a marker to make sure you're achieving all the things you need to be achieving. But the second role of the ARCP is to meet the GMC requirement for appraisal and revalidation. And the Dean is actually the responsible officer for trainees. So that's the 2 purposes of the ARCP. This is the gold guide, and if anyone has any questions about ARCP, or if there's anything that isn't covered, this is a huge document and is actually full of really useful information that's worth the read. It states within it that less than full-time trainees should have an ARCP at least annually, and it talks about the fact that less than full-time trainees should be achieving the competencies on the decision aid in a pro rata basis. So it's very clear and explicit about that. We'll touch on that in a few slides. It also talks about spreading the assessments throughout the year. So it's a good document and good reference. So I thought, where shall I start when preparing this talk? So I did a quick straw poll because I'm a Wessex trainee and have been through the ARCP process in Wessex, but what are other people doing? So this is a small straw poll of 4 other deaneries. And as you can see on the left of the screen, North West Peninsula and London are all doing annual ARCPs where they have a pro rata assessment. So the trainees all have their ARCP at the same time as everybody else, and they're expected to achieve the competencies on the decision aid in a pro rata basis. In Wessex, actually, we're doing things slightly differently currently. and trainees have a bespoke ARCP, and that depends, the timing of it depends on their proportion of less than full time. So if they're 80%, they'd have an ARCP every 15 months, so at the transition point. So what's my experience? So I've worked 60%, 70% and 80% of less than full time. I'm now a full-time trainee. My experiences really are, when I started a job, I felt like I had to prove that I was as committed as my full-time colleagues. And I think that's a feeling shared by other less than full-time trainees. When I first went less than full-time, actually, I had annual ARCPs, so at the same time as everybody else. So Wessex changed. And at the time, I think one of the most difficult things was knowing what the goalposts were. I remember sitting down with my educational supervisor as an ST3 who said, yeah, I may as well just achieve the competencies of a full-time trainee, and then there wouldn't be any questions, and it would be easier that way. And that does work. But I think that the most important thing really is to know what you're aiming for and for things to be clear. I later switched to the bespoke system where I had an ARCP each time I reached a transition point. So this, I'm not sure if it will play, but it's that game where the target is moving. And I think life is a lot easier when you know where the targets are and they don't keep moving. So this is not supposed to, this is the ARCP decision aid, and you can all find this on the training websites. But I just want to break this down because actually it's quite straightforward and quite easy to work out what you need to do if you're less than full time. So this is just a really quick example. So this is if you were a 60% trainee. So this is me back as an ST3 when I worked 60%. So this is the column for an ST3. And these are the things that you need to achieve. And we can simplify this, first of all, by taking out all the things that you don't need to achieve at ST3. So that's then cropped out. Already looks better. And then you can look at this table, and so this is the requirements for a full-time trainee, and then it's quite easy to work out which things would be different if you're 60%. So I've highlighted the green things. So an ALS certificate you need valid regardless of whether you're less than full-time or full-time. You need a satisfactory educational supervisor report, clearly, regardless of how you train. But the things that are different would be the common competencies and logbook of procedures. You'd be expected to have a logbook that progresses at 60% of a full-time trainee. Likewise, if you look at the CBD and ACAT requirements and the DOPS, these just need to be reduced to 60%. So these stars are all going to individually turn. So these can just simply be reduced to 60%, and then it's clear. And I think that this is actually quite an easy process to do, and something that you can do with your educational supervisor when you start, and then everybody knows where the goalposts are. So this is supposed to be a rugby player being knocked over to demonstrate that it's easier to hit your target if it doesn't move. So my take-home messages are that there is variability nationally. So the deaneries are not all doing things exactly the same way. I think that as a trainee, it's really important to review the ARCP decision aid at an early stage and sit down with your educational supervisor so you can agree what the goalposts are right at the beginning of the year. I think supervisors have a role to be aware of pro rata requirements for less than full-time trainees, and it would be really useful if ARCP panels could all be aware of the reduced decision aid as per the degree of how less than full-time a trainee is. And as I said, I think agreeing goalposts early makes the whole process a lot easier. So that's really all I wanted to say. That's my email. I'm more than happy for anyone at any time to contact me if you want any advice about anything. And that's my daughter climbing up a climbing wall. And it just shows that the training can be tough, but there's lots of people to support you along the way. Thanks.
Oh, thanks, Hannah. That's great. And I think we all struggle a bit with ARCPs and feel a little bit overwhelmed with what's required, and you've really simplified that. It's made me think, what was the issue? Because you made that sound really straightforward. So I'm looking forward to chatting a bit more about that at the end. I can see there's a comment in the chat already about that. I'm going to save all the questions and discussion for the end, just because I feel that they'll there'll be lots more. Okay, so I'm now going to ask Annemarie Brunswicker, who is an ST6 cardiothoracic surgical trainee in the Northwest, to deliver her talk, which is, she's going to cover an issue which is really quite challenging in both cardiology and surgery: how to ensure practical skills competence whilst training less than full time. So I think if the surgeons can do it, then surely the cardiologists can do it as well. So over to you, Annemarie. Thank you.
Right, I hope you can hear me. I'm just going to try and share my screen.
Yeah, we can.
Is that working? I hope so. Okay, great.
Yeah.
Yeah, so thank you very much for asking me to contribute this evening. So I train in the Northwest and have been less than full time for a short while now. It won't move on. Let's see. Ah, there we go. I started my training in 2015 and then took my summer maternity leave, went 80% less than full time. I'm now again in maternity leave. So I had my fair share of negotiating these issues that Hannah just mentioned in her talk about ARCPs, and have currently 2 little ones at home as well, who are hopefully asleep. Now, just to jump in with a little bit of theory about learning curves, because actually the learning curves of less than full-time trainees are not any different than that of full-time trainees. And that's my argument with going in almost any discussion with clinical supervisors. Every trainee starts off at sort of this point at the bottom of the curve, and then as they progress, move up to this point where they then eventually reach some sort of plateau where they can perform procedures independently. And essentially, just to reach this plateau usually just takes a certain number of procedures, which is sort of a bit of an individual number, or a certain time being exposed to the procedure. And that is pretty much the same for less than full-time and full-time trainees. And just to sort of briefly illustrate that I'm not making this up, this was a paper where they basically measured how long a surgeon would take to do a total knee replacement, and basically, as you can see, the time, whichever mathematical model you use, it plateaus after sort of 20 to 30 repetitions. And again, that was another paper that has a nice summary of various studies which looked into all sorts of surgical procedures, and they measured other outcomes than just the operating time, and all of them found that there was a certain plateau after either a certain number of cases or a certain number of years or months doing the procedure. And I think that's quite reassuring, because it just means that as soon as you've reached a certain exposure, you'll very likely be competent at what you're doing. And whether you reach this sort of exposure over a longer amount of time or short amount of time, that really shouldn't make an awful lot of difference. So I think there is at the moment nothing out there that the learning curves are in any way different for less than full-time trainees. And as Hannah has outlined, is we need to achieve the same numbers per full-time equivalent stage of training. So although my ST4 or 3 might be 1 year and 3 months, I still have to achieve the same as a full-time trainee in a year. And by the time of CCT, I should be at the same plateau stage of the learning curve, having achieved the full-time equivalent number of procedures and the full-time equivalent training time. And just to illustrate that for cardiothoracic surgery, so that is probably very different from cardiology, but we have sort of a sort of mixed system of assessing competency. So the first thing is index case numbers, and you can see that per year we are expected to do a certain amount of operation as first operator. Training times, we're not competency based, so you have to fulfill that criteria. And we have, again, similar to you guys, a set number of workplace-based assessments that need to be done at a certain level. And our clinical education supervisor also prompted to comment on operating skills in their report. So it's kind of a mixed bag of how we assess competency, but as you could see in these learning curves, time and case numbers play a huge role in that. And then that got me thinking about what the obstacle was that I sort of had in the course of my less than full-time training. And I think in surgery, it's very much in 3 areas, really, mostly work environment and often with trainers. And then there are also external factors that can play into that. So I guess with work environment, the rota can be a huge hindrance if it's not done well, especially if if the rota managers are not aware that you should be rostered pro rata, and that also, you know, should be applied to the type of duties you have. So if you're 80%, then you should have 80% of the operating time that a full-time person has, not just 50%. And I think that's really vital that that's applied. One thing I found out is sort of a bit of insidious in the rota is last-minute changes, and that can affect us quite a lot in less than full-time, because if I'm a full-time trainee and I'm there 5 days a week, if my consultant says, oh, you know, I've moved this operating list from the Thursday to the Monday, that is probably not a huge problem for a full-time trainee. But Monday is my childcare day. So if my only operating list of that week, because the other one has gone down due to audit meeting or something else, if that only list is then moved onto my non-operating, non-work day, then that is already a huge chunk of operating gone for me. So those things affect us a lot more. And I feel that can sometimes be an issue. Also, mandatory teaching being constantly on your operating day, not so much of a problem as if you're there all week, but if that's your only list in that week, that is a lot more important for your final numbers. And I guess the expectation to work on days off is also often found in surgical specialties, unfortunately, and that obviously kind of contradicts the whole principle of being less than full-time for childcare reason. You just can't come in on your days off because there is something else to be done. And I guess trainers who are not very experienced or don't quite buy into the less than full-time concept, that can be sometimes challenging to navigate. And external factors, of course, childcare issues we all know who have children, is that our nursery is shut and the childminders close, and they don't really want to wait for us to complete workplace-based assessments after our operating list. So these are sort of what I found were the most common obstacles. And how can we fix it? I think sort of from the tips and tricks box, taking ownership is a huge advantage. We feel, I think in surgical specialties in particular, just liaise with rota managers early to make sure that you're actually scheduled for the operating list that you need, and a appropriate percentage, and knowing the BMA guidance never hurts. Having a meeting early with the educational supervisor just to really go through these numbers and say, listen, 80% I need, how do we schedule this? When should be my childcare day, so we can optimize the operating list numbers? Just being a bit proactive about that goes a long way. And equally day to day, I think it's not just us who needs to be proactive, everyone needs to be proactive, and making the most of the opportunities you have, I think, is nowadays really not just something that affects us. Even full-time surgical trainees sometimes struggle for numbers, and that is something that we all share and we all have to work with. So being proactive, preparing lists, making sure that we know when the lists are, and if anything is swapped, sometimes you can accommodate, sometimes you can't, but that can help you to get that extra bit of experience here and there, which might make a difference. Simulation labs can be really helpful if you say your list goes down because one is cancelled because there is no beds, and the other one you're meant to be in the mandatory teaching day. Having some sort of simulation lab can really help to keep your hands going. And I guess supporting stakeholders is the other big thing. I wish that Hannah's explanation of the ARCP was available to ours, because often what I've encountered is that people forget that I'm less than full time, and then I go into the ARCP and they say, oh, why are your numbers so low? And it's like, well, because I work only at 80%, so therefore I only need to have 80% of what everyone else has. But I think I wouldn't blame them, because our portfolio is not constructed to display that at all. So you wouldn't know from opening my surgical portfolio that I'm less than full time, because it's hidden somewhere in some placement data, and it's not really obvious to see when the ARCP assess these things. And I think another thing that in the time of COVID sort of was quite interesting, and there was a survey amongst cardiothoracic trainees what their training experience was during this first peak, and the summary of this paper was about diminished training opportunities and how we should review our practices to make it all the new normal. And I think that's pretty much what should happen to training practical procedures for less than full time. It should be the new normal, because that's now the experience everyone has. Everyone's list got cancelled, and trainee experience was less than optimal, and they just have to work with it. And I think that's the same. We just have to make it work, and that's really important. And I think there are a few surgeons that share my view on that. So this is a colorectal surgeon from Sweden who wrote a paper in the Annals of the Royal College, and he sort of lined out how in Sweden they have a dedicated program director who basically makes sure that everyone gets the logbook procedures that they need. And this is a thoracic surgeon who visited us from Denmark. And when I asked him, said, how do you guys do it with sort of trainees who train less than full time, or generally just sticking to the European Working Time Directive? And he said, well, the time our trainees spend at work is prioritized as training time, as simple as that. So all the training program directors, education supervisors out there, I think you are crucial in making this work and helping us to develop a very diverse workforce. Thank you.
Thanks, Annemarie, that was brilliant, real food for thought. And I can see there's lots of questions and comments in the chat there, and I'm not ignoring them. We're going to come to them at the end of the session. So if you can stop sharing your screen, Annemarie.
Yeah, there we go.
Brilliant. And we'll move on now to Amy Burchell, who's an ST7 cardiology trainee in Bristol. And Amy is going to talk about rota scheduling for the less than full-time trainee. Thanks, Amy.
I'm hoping you can see my slides.
Yeah, we can.
Yeah. So I'm an ST7 cardiology trainee. I work 60%, and I'm currently specialising in heart failure and echo, as it sounds like most of the other less than full-time trainees do by the looks of things. So I'm not an expert at this, but I touched on the things that I think perhaps we all ought to think about when we're trying to put together a rota for less than full-time trainees. And some of those are perhaps more sort of practical aspects about rota structure, some of the things that Annemarie's already touched on in terms of access to training, annual leave entitlement, and then I've been looking at the BMA guidance, and there's a joint document between the BMA and NHS employers that covers quite a lot of this, and I've got the link to that at the end. As a bit of research into what I was going to say, I canvassed a perhaps well-known large medical mummies Facebook group to see if I could get any feedback on people's positive and negative experience of less than full-time training, particularly from other specialties beyond cardiology, to see if we had anything we could learn. I got one reply, but I thought their reply was very helpful, and it made a good point, and that was talk early. So talk to your trainee, talk to your supervisor, because you know, people can come up with a lot more of an effective and an individualized plan, but we often need a lot of notice, and putting that together well in advance is really important. And I thought that was a good point. I'm going to use some examples from my own life, so I'm sorry if that's the case, but maybe other people can comment later if they've had any other good or bad experiences that would be helpful to learn from. So talking about rota structure, so some of this is going to be determined by the trainee's requirements, and particularly, for example, the percentage of less than full time that you're going to work, and whether or not that needs to be on fixed days. As we know, most people are less than full time for caring requirements, and if you're trying to book a nursery or other childcare, then usually you have to commit to fixed days. And so once those days are decided upon, then it's quite difficult to change them without significant notice. Certainly when I came into training, I said, right, I'm going to be 60%, I can work any 3 days of the week, but once we set them, then I probably need to keep those days fixed unless I've got a significant period of notice. And that notice period also applies to the rota coming out. So we know that the BMA minimum requirement is that we get a rota within 6 weeks, but anyone who's tried to arrange a nursery or other childcare will know that potentially waiting lists and other things take a lot longer than that. And so really just having as much notice as possible, talking as early as possible, and also particularly about night shifts, because they're often quite difficult to factor in as they may encroach on non-working days. So plenty of notice where possible. The other thing that may be dictated by where you're working is whether this is perhaps more applicable to cardiology, but whether you're in a DGH in a pooled GIM rota with trainees from other subspecialties, or whether you're perhaps in a tertiary centre in a subspecialty cardiology rota. And there are pros and cons to both of these. So in a bigger GIM rota, there may be more less than full-time trainees, and so there's perhaps more option for slot shares in terms of covering the on-call component of the rota, but you may not perhaps be in as close contact with the rota manager or whoever's designing the rota. If you're in a small subspecialty rota, it may be that you are the only less than full-time trainee, or there aren't as many of you, and so that may make a job share or a slot share more difficult. But you may find that you're in closer contact with the person writing the rota, and that can be helpful to discuss things directly. The other thing that the BMA guidance touches on is the specifics of what these different things are. So a slot share is where 2 or more trainees are working to cover one on-call slot in the rota, but they may work in total more than 100%. They may work on the same days, they may overlap at times, but they cover that one on-call slot. A job share is where 2 people are basically one, and so they do 50-50. Their contracts are exactly the same. They do 50% of the on-call, 50% of the days. So it's as if you've got one person, except they're actually 2. And actually, one of probably the most common scenarios is to have a less than full-time trainee in a full-time slot, unless you're very lucky and you can have a supernumerary less than full-time trainee, but I've not found one of those yet. And so that means you're going to have rota gaps, and again, having to work out how you're going to cover those. I think it's important to think outside the box. So there are concepts of things like mixed slot share posts. So the example here is that if you have 3 people who are 60%, 60%, 80%, your 200% can then cover 2 slots in a rota. But that does obviously require you to have multiple less than full-time trainees working within that sort of a pattern to make it work. And the other thing is to think about the other people that you have available to potentially either slot share with or cover your rota gaps. So I think we're perhaps more talking about less than full-time training in terms of people who are not having clinical commitments for the other percentage of their time. But remember, there are people like academic trainees who may be on a certain percentage of clinical training, research fellows, and that's how it works where I'm based. So the other half of my slot is covered by someone who's on UPR and does research during the day, but does the other percentage of my on-call slot to cover the out-of-hours rota. And you might even have people like post-CCT fellows who want to keep a bit of extra cash coming in and are willing to contribute. So think of all the people that you've got out there. How many people can you use to help support the rota, and particularly to add flexibility for people who are less than full-time? As has already been discussed, shifts should be pro rata. So think about whether you're on a day shift, long days, nights, twilights. You should be doing 60% of each of those types of shift, or as near as possible. It doesn't always work out perfectly. And ultimately, the rota pattern as well should be similar to the pattern for full-time trainees, so that it looks like the same job, just 60% of it. Nights are particularly tricky. Certainly, most places you will do blocks of nights in some form. We do 4 nights during the week and 3 over a weekend. And if you only work 3 days a week, then how do you handle that block of particularly the 4 weekday nights? Personally, I've chosen to do the full block because I find that it encroaches less on my family life if I do that less frequently, but that I have to have notice because I have to access additional childcare to do that. The other less than full-time trainee where I work does split weeks, so she only does the 2 nights for the week, and that's what works best for her. So it's about discussing it and finding out what's best for each individual. The other thing I've flagged is 0 days. So these are put into the rota to make sure you have adequate break times, and to make sure that your mean number of hours per week is appropriate. And as a less than full-time trainee, your mean number of hours per week should be a pro rata percentage ultimately compared to your other colleagues. And it's making sure that you get or take the right number of 0 days to reflect that. And one example I had of that was when we went into a rapidly into an emergency rota during the spring to cover COVID. We were working a rota that had a lot more nights and weekends to cross-cover each other in case of sickness. And if I didn't take all the 0 days, I would have been working way too many days. So you just have to keep an eye on that. We've already touched on this, so I'll be reasonably brief, but access to training should also be pro rata, and that's clinics, that's lists. Everything should be pro rata as possible. And again, a common catch for this one is things like clinics. If a full-time trainee is doing, say, 1 clinic a week, then a less than full-time trainee, if you're doing 1 clinic a week, you're actually doing more clinic than your full-time equivalent. And so it's being aware of that and making sure that that's factored into a rota, and similar for getting opportunities in terms of practical lists. when you're coming up with which days to work, are there any what I've recalled core sessions? So are there any things that occur perhaps on a particular day of the week that really ideally all trainees should be attending? So the example for me here would have been our departmental MDT, which is on a Tuesday morning. And when at the beginning I said I can work any 3 days, which days are we going to go for? One of the days was to say, well, let's do a Tuesday, because that includes the cardiothoracic cardiology MDT and actually also the heart failure MDT. And so again, it's about talking early, which are the core training days, which days do the relevant lists, relevant clinics occur, and can you factor that in when you're trying to look at a schedule. Training days, so regional training days. So the guidance is that less than full-time trainees should attend a minimum of a pro rata rate of these. And again, it's about thinking about how to make sure that all trainees can attend as many as possible. If there aren't many less than full-time trainees, is there a day of the week that works for everyone? And is that the best day to run your training days? Or if actually there are people who are working different combinations, is it better to vary the day of the week so that it's not the same person missing out each time? And that may vary between region as to what the best way of handling it is, but it's worth thinking about. And again, notice, if I have lots of notice, I might be able to get childcare for a training day on a non-working day, but I need time to plan that. And again, educational events. So this is perhaps thinking a bit more outside the box, the things that aren't happening so much at the moment, the evening meetings, the regional symposium on heart failure, whatever it might be. And again, if you're planning that sort of thing, just think about how you can optimize access for everyone, both less than and full-time trainees. And it's similar ideas about varying the day of the week, varying the time. Things seem to often be scheduled at bedtime for small children, but it's just something to think about. And we've all discovered during COVID that you can use digital to work around some of this. So I'm certainly able to get to things that aren't on my training days of an evening more easily if they're online. And also recording events so that people who aren't able to attend on a particular day because they're not working can still access that opportunity. Briefly, leave entitlement. Same thing, it should be pro rata. So how much leave you get depends on how long you've been working for the NHS ultimately, but you'll be able to check that from your contract. But it should be pro rata as a percentage if you're less than full time. And the thing I picked up on looking at this is that it's pro rata bank holidays as well. So if the example here is if you're a less than full time trainee and you've done 5 years of service to the NHS, and you work 60%, you would get 24 days of leave, and that's annual leave and bank holidays as leave within a year. The sums for that are below, so 60% of 32 days of annual leave gives you 19 days of annual leave, and then 60% of 8 days worth of bank holidays gives you 5 bank holidays. So if you bundle that all together as leave, if you're working a bank holiday, because you've already factored that into your leave, you then don't get a lieu day because that's sort of already added in your annual leave allowance. You're going to have that as a leave day anyway. But if you're not working, it's like you're taking a day of annual leave, you're taking a fixed day of leave and you need it to be deducted. There's various ways of getting your head around it. You can either split it into annual leave and bank holidays and making sure that you're doing the appropriate number of bank holidays, or you can sort of create it as one big blob of leave, which I find easier because I don't work a Monday, but I do work a Friday. So there's certain bank holidays that I would and wouldn't get. The other thing is with the BMA, interesting, if you're 0 days on a bank holiday, you would still get a lieu day, or in my way of thinking about it, I don't need to deduct that from my annual leave allowance. Same for study leave, so pro rata. And if you have study leave on a non-working day, the BMA guidance is that you should then get TOIL, so time off in lieu, with regards to that. So if it's a conference or something that's on a non-working day, you should get time back. And then I guess the important thing is no one else is going to keep tabs perhaps on some of these things, and so to know where you stand. And these are some of the bits that I picked out from the good rostering guide from the BMA. So if you're in a slot share and you add up to more than 100%, so you've got 60% people working one slot, then the out of hours should be split equally to cover at 50% each. But if there are remaining hours that you need to work to meet your percentage employment, then if possible, they should be made up with educationally beneficial normal working hours. I mean, that's in favour of less than full, potentially supporting less than full-time trainees, and perhaps something I hadn't really picked up on before. The working patterns should maintain the working days, your normal working days, as much as possible. And the main example of this is nights. So if you're doing a block of nights, it should really only encroach on one non-working day. So if you normally work Monday to Wednesday, either it should encroach on the Sunday coming into nights, or perhaps the Thursday coming off nights, but not both, unless, like me, you've made an agreement to do something different. And again, unless it's been agreed, you shouldn't be rostered to work on days you're not scheduled to be there. So you shouldn't be put on a working day on one of your non-working days and then be expected to swap it afterwards. Ideally, whoever's writing the rota should know your working days, and that should be factored in wherever possible, and that's the BMA recommendation. And I've put where you know where you stand, but I've also put know where you can flex. So, you know, we all have different situations, we all have, you know, different support networks or lack of support networks. And I think the main thing is just to know what you can give on and what you can't give on. I cannot be on call at the same time as my husband, that doesn't work. But I can perhaps be a bit more flexible about attending some training days on non-working days if I've got notice. I do my nights as a block because I find that works better for me. I could work any 3 days so long as we plan it well in advance. So it's just having that clear in your own mind when you go into those conversations. So we've talked about planning early. We've talked about knowing your life and where you can and can't flex. Everything should be pro rata for everything. And ultimately that should give you an individualized work schedule. And as we've sort of talked about, and the others have touched on, that sometimes you feel like you're not there, or you're not, am I around enough? But as a less than full-time trainee, you are doing the same number of days of training as a full-time trainee. You're just doing those days of training over a longer period of time. And I find that quite helpful as a concept when I sometimes feel I'm not there. I'm like, well, I'm just there on different days. And so I think that's quite helpful. And these are some of the links to the guidance. So the Good Rostering Guide is where a lot of these things come from, and that's a joint BMA NHS employers document. I think most deanery websites will have policy on less than full-time training. The 7 deanery where I'm based, it mainly talks about eligibility and application for less than full-time training and less about the nitty-gritty of how you actually then do it. I found a really good pack from the University Hospitals Leicester NHS Trust, which I've put a link to on here, and that actually goes into a lot more of these logistics about, you know, how much leave should you have, how do you actually do it, and there's also a link to some information about pay and how that works as well. So those are available if anyone will find them helpful.
Thanks, Amy. That was brilliant. I think it's as you said, it's a real minefield trying to get your head around your rota and leave, study leave, annual leave. I was a less than full-time trainee for a lot of my cardiology training, and I realised that nobody else really understood how it worked, and it was up to me to make sure that I understood it and made it work. So that was brilliant. Thank you. If you stop sharing your screen now, and I'm going to ask Bil Kirmani, who is a consultant cardiothoracic surgeon at Liverpool Heart and Chest Hospital, and he's also the less than full-time champion for Northwest Cardiothoracic Surgery. Is that the right title, Bill? You're muted there. Can't hear you, Bill.
Sorry, can you hear me now?
Oh, there you are. There. So Bill was the first cardiothoracic surgeon to take shared parental leave in the UK, I think. And he's going to discuss his experience with us tonight. Over to you.
So thank you very much. As Rebecca's already said, I'm a cardiac surgeon in Liverpool, and being the first cardiac surgeon in the UK to take shared parental leave, I think that makes me the resident expert. I'm also married to a surgeon, and I was just going to tell you my experience of shared parental leave. So what I wanted to talk about was men looking after babies, the logistics and practicalities of shared parental leave, which is a slightly different topic to the flexible working that we've talked about so far. The finances of taking shared parental leave, how to maintain your professional skills when you're off work for a prolonged period of time, and some of the benefits and disadvantages as I saw it. Probably what I'm going to end up doing is mostly just showing you baby pictures. So men looking after babies is somewhat a contentious issue. In cardiac surgery, I was certainly told that it was a ridiculous notion that I should be going and looking after a babe in swaddling clothes. And it's something that we're gradually becoming more aware of, and something that is more reasonable. However, just 1% of eligible UK parents, not just in medicine or surgery, but across the UK, take the opportunity to take shared parental leave. And before anybody reports me for giving my child a pipe, that's my brother from about 40 years ago. The logistics and practicalities in some ways are very similar to what everybody else has talked about today. I think you need to talk to everybody early. You got to know what your rights are, but you've also got to know what your responsibilities are. And sometimes the most difficult thing is speaking to the people who are going to facilitate that. Don't know if this is going to play.
Are you okay?
So that was actual footage of my associate medical director taking the news that I was going to be taking 3 months off work to look after my child. And sometimes it feels like the people who you are going to be asking are sticking their heads in the sand and trying to deny the fact that it's going to happen. There's sometimes feels like there's some screaming and shouting and insidious snipes at you. What you've got to remember is that shared parental leave is something that's relatively new for a lot of specialties and a lot of human resources. So getting the paperwork done is relatively simple, but expect to be telling or reminding the various departments who you're going to need to liaise with how it works and what they should be doing. You can share a total of 50 weeks with your partner, and you can alternate. So if you want to take a week at a time each, that's absolutely fine, but only the first lot of maternity leave gets NHS pay. So that's something to take into account when you're looking at your finances. So, for example, with the NHS, which has got a very generous maternity pay allowance, you get 8 weeks of full pay, 18 weeks of half pay, and 13 weeks of statutory maternity pay or maternal allowance, followed by 13 weeks of unpaid pay to make up the entire year. With shared parental leave, all you get is the statutory amount. So once you leave the maternity leave pay structure, you go onto the shared parental leave for either parent. So if then you swap back and decide that the mother is going to take the next lot of maternity leave, you don't return to the maternity pay structure, you stay on the shared parental pay. So what we did was we took 6 months up until the start of statutory maternity pay, and then I took my 3 months after that. So maintaining professional skills sometimes feels like you're taking chopsticks to the table after you've been off for a period of time, and with the kinds of skills that you might require for cardiology or cardiac surgery, you may be more conscious of the fact that you spend some time off, even if you come back from a long holiday. What my surgical wife reminded me was that a lot of female colleagues achieve that successfully after 12 months or more of maternity leave, and my wife told me to woman up and get on with it. Realistically though, you do have to sometimes do things at a slightly slower pace when you go back, and the keeping in touch days that are applicable for maternity leave aren't necessarily applicable to shared parental leave. So it's good to have those discussions early on. Certainly my trust was very supportive and made sure that I had additional ways of getting back into the groove when I came back. It's important to be bold, and I think some of the other speakers have also alluded to this. If you don't ask, a lot of departments will slide back into what they know and assume that you're happy with the situation as it is. So be realistic with yourself and ask for the things that you think that you need. As far as the benefits and disadvantages of taking shared parental leave go, it certainly enhances your relationship with your child and your partner, and gives you the ability to understand what your colleagues who have been taking maternity leave for a long time and facing the consequent sort of behaviours from the workplace with that alike. It's a realization of what work-life balance can be, because when your priorities shift, you understand that actually you don't have to be at work the whole time in order to demonstrate your dedication to the specialty, and you equally don't need to sacrifice everything at home in order to be a good clinician. And it paves the way for equality in the workplace, because if more men take shared parental leave, there won't be the sorts of notions when employing people that a certain group are going to take time off in order to be carers, and hopefully it will help to enhance equality in the workplace. It is expensive. I think everything about having a child is, and if you don't have a supportive department, it can sometimes cast doubts about your dedication or your priorities. Sometimes there is additional work to do in order to stay on an even keel. However, ultimately, the main advantage is the memories that you're going to generate. Thanks very much.
Oh, that's fantastic, Bill. Thank you. Gorgeous baby pictures. Okay, so we have around 30 minutes left for questions and discussion. So we'd like this to be as interactive as it can be online. So feel free to put your cameras on, or if you'd prefer to stay hidden, that's fine as well. You can ask questions in the chat function, or Sarah, can you raise a hand on Zoom or not? Does it? No, you can't. Okay, so either put something in the chat or put your camera on and speak up. I'm going to hand over at this point to Sarah Birkhoelzer, who's cardiology trainee and BJCA Women in Cardiology and less than full-time rep, and she's going to chair this last half-hour session. So over to you, Sarah.
Thank you, Rebecca, and thank you to all the speakers. I hope I don't just speak for myself, but I thought that was a very inspiring hour. And who doesn't want to work flexibly after what we've just heard? Starting with Rebecca about changing about the changing workforce, and how we listen to the medical students, how they're choosing their specialty based on the future of how they can work flexibly. And I think in particular cardiology needs to look at those medical students. And thank you, Hannah, for your amazing talk. It feels like it is pretty straightforward. Just take 60% of everything, look at your ARCP guide, and that's it. And it's just a wonderful illustration how a sort of rather complex issue can be broken down, and actually if you communicate it to all and everybody knows a little bit about it, it doesn't actually isn't actually that difficult. And I think certainly what all of the speakers this evening demonstrated is that it is possible. If you want to do it, you can do it. You can take parental leave as a cardiothoracic surgeon, so you can do it as a cardiologist as well, and you can work flexibly. Yes, it takes a bit of organization, but I think everybody has demonstrated with a bit of background knowledge and clear communication and advanced planning, we should be able to raise our children and have a career in cardiology or cardiac specialties. Thank you for Annemarie. I think that was very inspiring to share your story. I don't think many people know many less than full-time female cardiothoracic surgeons, so very inspiring to hear that it is possible. And in particular, the main concerns for cardiologists, the sort of working in particular interventional cardiology and possibly EP, to keep your skills up. I think you demonstrated that it is possible as long as you have the numbers. It will take a bit longer because you do less numbers a week, but as long as the numbers work out, you will be able to do it. And before I sort of allow questions from the wider audience, I wondered whether there are some training program directors around who might want to share their thoughts on what has been said.
So I'm happy to come in if it's helpful. So I'm Dan Sader, I'm South Thames Training Programme Director. I've been going for about 1.5 years. We have, I think, one less than full-time trainee. I mean, this has been really helpful for me. And I think probably one of the things I would probably say to everybody who's thinking about doing this is, yes, taking some ownership of it is helpful for those around you, because I suppose it helps us to know what we need to do to help you. If you like, it sort of starts from yourselves, and then we try to, I mean, certainly how I would see my role is to try to help you facilitate what you need to allow you to achieve the training requirement, obviously the TPD hat on, the training requirements that are needed. The only other thing I was going to say as a general comment around ARCP stuff was, clearly as a TPD, what you see across trainees, some trainees are just better at doing this sort of thing than others. I think it's what was being shown was really helpful in terms of looking at the ARCP grid in a slightly different way. But bear in mind, all the ARCP grid is this is what you need to do in order to get through. You can aim higher. So I think it's useful to have what you definitely need. So if you're at 60% full time, what do you definitely need to do? But that, I don't think necessarily people need to walk away from thinking, okay, well, that is all I need to do and I'll stop there. Some people, some high flying trainees will aim higher, but at least you know where the bar is, and that's also helpful from our point of view as well. So last thing I was going to say is thank you very much. I mean, as I say, that was brilliant for me. I learned a huge amount from all of that, so thank you.
Thank you very much, Dan, for sharing your thoughts on this. And I think that's what Hannah made pretty clear, is that we need to know where the bar is, where the goal is, to be able to achieve it. And I think it's, again, what sort of Amy alluded to, it's all about the communication between the training program director and the individual. How flexibly can you push certain rules and what can happen? But I think it's also nice to realize that you can feel empowered about knowing what the rules are, because I think in particular from my own experience, I was in lots of situations where I had to tell HR and my supervisors how it should work and how the rota should work. And I think that's certainly something to take home as well, is that we we ourselves need to know how it works, and then because other people might not have any interest. And I think what also came up in the chat, or in particular during the course, is sort of pro rata training, pro rata educational days. And I think what Lynn said at the beginning, the fact that this is different for less than full-time consultants. I mean, the majority of people here are trainees, but what have you got any thoughts on that, Lynn?
Well, as a consultant, the CPD requirements are set by GMC, and obviously trainees, it's largely around mandatory training days. But the GMC say that you have to get 50 CPD points per year. And that spans across kind of internal trust stuff like mandatory training, grand rounds, that kind of thing, personal study, and external events like courses and conferences. And a certain proportion of your CPD points per year have to be on external events. And as a less than full-time consultant, I have to get the same number of CPD points as my full-time consultant colleagues. So that is one difference as a consultant if you're going to be working less than full-time. Am I allowed to make one tiny point as well? A bit like Bill, so I'm a consultant cardiologist, and like Bill, I've done something a little bit unusual in that I have been lucky enough to work as a job sharing consultant cardiologist, which is not common. And if anybody who follows me on Twitter knows that I will preach at any point in time, the most important thing about choosing your consultant job is choosing your colleagues. And particularly if you're planning to work less than full time as a consultant, as Bill said, if you don't ask, you don't get. But if you choose your colleagues and choose kind colleagues, I and my job share have also had really incredible support from our colleagues in working full time, and I can't preach that enough to you, to choose your colleagues wisely.
Thank you very much. I'm not sure whether you have that much choice, because there are not many consultant posts lined up when you're ready to do so. But a lot of
everyone, anybody who wants a job, come and talk to me.
I think a lot of people are concerned about working less than full time due to the ever-changing curriculum, and I don't know whether Alison would like to sort of reassure or not reassure those who've been less than full time for many years, and in particular when it now comes to the GIM dual accreditation, which had upset many cardiology trainees, in particular those at the later stage of training. Is there anything you might want to share with the group?
I think if you're a fairly senior trainee, whatever the reason, whether you've done OOP or you've done maternity leave or whatever else, and you don't want to do general medicine anymore, then you need to fill in the piece of paper and send it to your HE deanery to say so, and you need to do that immediately. If you were appointed this year to ST3, and anyone appointed next year to ST3 will not be able to relinquish GIM at all, and will, in the fullness of time, transition to the new dual accredited GIM and cardiology training program. It is not completely clear what the situation is for people appointed before 2020. And indeed, if you're an ST4 at the moment, you're right at the beginning of your career, you are going to end up in the dual accredited situation. And so probably, my advice to anybody in ST4 is that it's too early for you to know whether you want to give up GIM, and you should continue with both. For people who are more long in the tooth than that and may have done out of program research or taken various points of maternity leave, who know for sure that they have done general medicine a long time ago and they don't want to do it again, then they need to fill in the piece of paper that says, thank you very much, I want to give up GIM, and they need to do it quickly.
Thank you very much. I think that's pretty clear. I mean, we also need to keep in mind that the consultant posts, and whenever we're finally ready to become consultants, might only cover sort of GIM and cardiology training. So it's certainly a controversial topic across trainees and the training program director and the specialty advisory group. So to come back to the ARCPs, and maybe Hannah, would you be able to just say a sentence about the sort of difference? I think there were a couple of questions, what type of ARCP is better, and what are the benefits for maybe the trainee, or why would you do one way or the other? Maybe why has Wessex changed?
Yeah, I can give my opinion, and then if anyone else wants to add theirs, I think that would be really useful. Dan Sadio actually asked me this the other day. I think personally, having done both a pro rata ARCP, which, just to recap, is an ARCP when you transition. So if you're 80% every 15 months, so you use the normal ARCP decision aid, versus having an annual ARCP where you have pro rata competencies assessed. I personally actually don't think it makes a difference. I think if you know the goalposts and you know when it is and you plan, I don't honestly think it makes a difference.
Thank you. For those who had that question, if there's still something unclear, just come back in the chat. May I invite Bill and Annemarie to sort of talk about the sort of practical aspects about working less than full time and getting this experience, but also There are a huge number of cardiology registrars in well, huge number, but I know loads who are on maternity leave. Being on maternity leave myself, I grouped up. And how is it to come back? I mean, a lot of concerns, obviously, to have loss of confidence, and in particular in sort of more practical areas, either in the cath lab or obviously in theatre. How do you prepare for that, or what's the transition period like? I don't know who of you, maybe both, want to comment.
Do you want to go first, Annemarie? Yeah, I'm just going to throw you into the deep end.
That's muted. Right, so I think, well, I've been out a year last time with my first child, and definitely it's not, it takes a little transition to get back to things. And what helps firstly is to use sort of low fidelity simulation. We call it, it's very fancy, just stitching two rubber tubes together to practice just keep your hands from going a bit rusty. If you do that every now and then, that can hugely help just to stay a little bit in the practical level, although you will still need a bit of transition time when you come back. And I specifically asked for that for senior colleagues to be around when I did procedures for the first time again, and even procedures that I was very confident with. I just had a second pair of eyes on it just to make absolutely sure I was okay and didn't miss out anything in particular. But I think that for the really simple stuff, you just need one occasion and you're back flying. It's like riding a bicycle. But with the more complex stuff, it definitely took maybe a month or two to really get back up running, especially with confidence level, I think, to be able to go through a more complex procedure like a thoracic procedure or something. So that took me a little bit longer, I would have thought. I don't know what your experience was then, Bill.
Yeah, well, I didn't have that long off, but as a consultant, going back in and having to be on the right side of the table without a senior colleague is sometimes quite daunting. I think what you've got to do is just be realistic, and if you think that you're coming back in with some sort of anxieties about how you're going to get on with the first case, and it does actually feel like getting back on a bike. So my first case, I had a senior colleague who said that he would be around. He loitered around theatre, made snarky comments and stuck his head over the drapes from time to time to make sure that I was happy. Equally, I think in order to make sure that your patients are safe, you have to be honest with yourself. So if you think that your hands are going to be rusty and you haven't, got it back into your head like you had before you went off, ask to go in with a colleague, ask if they'll stand and be your first assistants, and don't put your pride before the patient, I think is probably the most important thing I would say.
Thank you very much. That's brilliant. And if I go back to Annemarie, I think a lot of concerns, in particular for junior registrars choosing their subspecialty, is that you can't do intervention or EP, probably more intervention, because it's practical. You want to have a family, you want to work less than full time. Can you sort of tell us about what are the sort of reasons why you should be doing it, or sort of break some barriers to encourage those junior registrars to choose interventional cardiology as a sort of practical specialty, and they still be able to work less than full time and still be able to end up as a competent interventional cardiologist?
I think the best argument is probably to look at all our academic colleagues who do 75% clinical and 25% research. And there are quite a few academic cardiothoracic surgeons out there with that sort of model. And I guess their practical skills are not all that much worse than everyone else's, if not better. So I guess on the whole, as I've shown with these learning curves, is that you're not a better or worse or in any way different learner just by being less than full time. So as long as you have your exposure, as in accordance to what percentage you work, then in time you'll just get to your own plateau. And just to illustrate this, I did like a little experiment in one of my previous departments where I mapped everybody's learning curve and just tried to figure out when they would reach their plateau when they introduced a new technique. And I thought that's really interesting. I just see how long all these consultants take to learn it and when are they plateauing with their procedure time. And it's really interesting because some had a plateau reached really early at sort of 20, 30 cases, others took 50, 60 cases to get to their plateau. So it's really individual. So say if you are a really fast learner and you're less than full time, you might already be at your plateau after 30 cases. And there might be a full-time trainee who plateaus after 60, 70. So they would probably take as long to learn as you do with less exposure. So it's so individual that I think it's really hard to make like a general judgment. But by all means, I don't think it should ever be a sort of off-putting any practical skills just being less exposed. And if you're really worried about it, there are simulation ways to keep your hands going, even if you're at home and you have a minute to practice or expose. I definitely think it's possible. I think the obstacles are more the work environment and sometimes even colleagues than the actual practical skills.
Thank you. And that sort of comes back to what Lynn said, choose your colleagues. And I think obstetricians and gynecologists have really demonstrated exactly what you've just said, because their specialty that is, although it sounds very different, it's very close to cardiology, where you have some medical aspect, but also some procedural aspect. And their specialty is 50-50, 50% female, 50% male, and the majority of females are working less than full time. So it is possible, and I think for those junior registrars or those who haven't decided on a subspecialty, I think it's going where your heart is and what you enjoy, and you'll be good at it regardless of whether you work less than full time. And maybe you are that person who managed to get the peak of the curve at sort of 40 rather than 60 or 70. So I think that was a really valuable comment, and I hope that sort of dismissed a couple of myths and stopping those going into interventional cardiology or other procedural aspects. Are there some other questions? People who want to maybe switch their camera on and say something, maybe Amy?
I just a couple of things I was going to, oh, sorry. A couple of things I was going to pick up on. I was out for 5.5 years doing a PhD and lots of babies and part-time PhDs. So when I came back into training, I'd been out for a really long time. I'd done bits and bobs, but it was quite different to perhaps just a year of maternity leave. And I definitely couldn't have gone straight back into everything again. And again, I just think it comes back to talking to people. You need to know what you feel comfortable with. And I had almost a return to training placement. I'd completed ST5, but probably wasn't ready then to go straight into ST6. And also the curriculum had changed hugely while I'd been out of training. So, what works for one person may or may not work for another, but it is about talking about it. And I had almost like a return to work placement, in which everyone knew my situation. We all knew that I'd been out for a while. And you do pick things back up again. It's not like starting again. You have done it all before, but it is about talking to people and planning things in advance. When I came back, I don't think the concept of support, so your hospital should have a support, so a support for return to training leader, representative, and I didn't access that, but that is another port of call for people that this is happening more and more commonly, and people are recognizing that there is a need to kind of get back into the groove when you come back. And so just speaking to people and accessing the resources available. The other point was the ARCP scenario, because I think that is difficult sometimes when you are less than full time. My deanery, generally ARCPs people once a year, regardless of whether you're full time or less than full time, but they do have 2 ARCP sessions a year. And so generally speaking, it's whichever one fits best with where you're at. But I think there are certain points where you're transitioning from one stage to another, where actually having an ARCP at the right time for you really does matter. So for example, if you're going from ST5 into ST6 and you've got to have kind of completed core cardiology and get into your subspecialty training, if that ARCP doesn't fall at the right time, you slightly end up in limbo. And I think at that point, you do need to talk about whether you can get an ARCP close to the right time so that you can potentially transition or as close as possible so that that works. And similarly, PYA, I know that hasn't been happening quite the same way this year, but there is, I think, transitioning from ST to ST4, it's important that you're making progress and that you're achieving some assessments and the right sort of numbers of procedures and working through the curriculum. But there are some other points where we're actually having something that fits with a time point for where you are rather than where a year is more important. And our deanery I think as I've come through, I've been in training for ages, and I think they have got better and better at being aware of that. And they're slotting an extra session in March this year for a couple of people who are completely out of sync, because that fits in, and they wouldn't normally have done something like that. So I think it's improving, and people are more and more aware. We've got a really good PD who's very much aware of these sorts of things at the moment. Again, just talk about it and plan these things, but people won't ask. You're the one who probably has to lead, to prompt it. If it's going to be completely out of sync, I ended up in limbo at one point where I wasn't really sure whether I was an ST5 or an ST6 or what, because I'd fallen between, gaps, and it's just trying to avoid that sort of thing.
Thank you, Amy. I also think you've put in the chat the sort of support, the local support services, and they actually are called like this. I have had 2 times out of training, and the first time I had no support, didn't know what happened, didn't even know what a keep in touch day was, and ended up returning on night shifts, which was less pleasant. And this time I had an email from a local return to work champion who, it was like 2-page email about support links. I've attended a webinar of about to return to work. There's access to coaching, there's separate access to mentoring. And yeah, I felt like really warmly welcomed back into the world of cardiology. And this is Wessex and Thameswelly, I think, from Health Education England. So it's called Support, as Amy put in the chat. And I think you have to be a little bit sort of proactive. I think there would have possibly been support for me first time round, which I just wasn't aware of what was possible. And now I'm going all in. So I will report how it's going. But I think things have changed. And as you said, Amy, over the years, there's certainly people are more aware of the challenges and barriers, and there is support if you ask for it. So everybody should be encouraged to either ask their clinical or educational supervisor or training program director. It is possible.
Can I just make a point, Sarah, that all of you who pursue less than full-time training know far more about it than anybody else. And the point Hannah made earlier that you need to lead it, and various other people have said the same, is absolutely right. You know more about it than everyone else. So take hold of it. Don't have things done to you. Go along and say, this is what needs to happen. This is how it can work. You will have a very good idea about how it works. And you will have a much better idea about how it works than absolutely anybody else who's ever had anything to do with it. So go along and say, here is the solution. Don't go along and say, I am a problem. And the other thing I would say to anybody who's listening who is not yet a cardiology trainee is, for God's sake, don't listen to those people who suck their teeth and tell you can't do it because you're a girl. Someone told me nearly 30 years ago that I couldn't be a cardiologist because I was a girl. I chose to ignore them because a lot of other men told me, well, what does that matter? What's that got to do with it? And don't take any notice of these people who suck their teeth and tell you it's impossible. It's not impossible. It's just a mindset. If it's what you want to do, go and do it. Don't wake up when you're 50 and think, I wonder if I could have managed that, but I didn't have the courage to try. Just try. If it doesn't work, you can do something else, okay? But if you never try, you will wake up when you're 50 thinking, oh, could I have done that? And you'll see all your male colleagues who went off and did the same, and you'll wonder, could I have done that? And it's the same once you're in cardiology. You want to do EP where there are no women except Ashley Nisbet. Well, I'm sorry, there are probably a few others that I don't know about. But anyway, and in intervention, there are no women. Well, there's me, there's a couple of other people, but people suck their teeth all the time and say you can't do it. Don't believe them. Just give it a go. If it doesn't work, you can choose something else. But please do not wake up when you're 50 and think, I wonder, could I have done that? Try it. If it works, do something else. If it doesn't work, rather, do something else. But for most of you, it will work perfectly well.
I think nobody else could have finished this meeting better than you. I think we all feel truly inspired.
Just because I'm old.
That's what you said. I think it is
old and decrepit.
But you went ahead, and I mean, we are kind of whinging about the situation, what we have now, and we're so advanced to what was even 10 years ago. So I think we are privileged, more privileged than you have been, but you've been leading the way and leading women in cardiology, demonstrating it is possible. And yes, it might be challenging at times, but nobody said it's going to be easy. But, you know, if there's something you want to do, go and do it. And I think there are enough women here, certainly those who have the screen on. Sorry, Bill, but there are a lot of
Bill's
women
a girl, clearly.
I'm an honorary girl.
Exactly. And might I add, that is the highest form of praise, as Bill, you have clearly recognised.
Clearly. And, you know, I want to have the best colleagues, and I just can't believe that the best colleagues come in the form of the, you know, sort of 90% men that we have in cardiac surgery. I know that women outperform men in lots of medical specialties, including cardiology, and it's because people suck their teeth, as you say, and put naysaying thoughts into your mind. So I'd love to see more women come into cardiac surgery as well as cardiology.
Thank you very much, Bill. Rebecca, do you want to say the last words before we go off and have a cold drink?
I don't think there's anything else for me to say apart from thanks to all the speakers. It's some really good talks, some real food for thought there, and I hope it's been useful for those listening. And thank you to you all for joining us. We appreciate you giving up your Thursday evening. We're hoping to run a few more webinars over in the future, and obviously we're learning as we go. So if anyone's got any feedback, suggestions, comments, or if you haven't been able to make a comment during the session this evening, please feel free to email Sarah or myself or any of the speakers. We're all open to suggestions. And I think we'll finish there. So thank you very much, everyone. Good night.